very much, Mary V. Good morning, everybody. Unfortunately, my talk for the next few minutes or so will not be as sexy and attractive as all the previous talks with all the novel drugs and exciting new molecules, because I'll speak about stem cell mobilization and try to convince you to avoid chemotherapy-based mobilization. I felt that this is really something important, although we rarely speak about this because it is established that this is standard of care, and I'll try to show you that there's no standard of care and maybe time has come to change. So obviously everybody is convinced here that, at least in a European context, this is the EBMT data, myeloma and plasma cell dyscrasia represent more than 50% of auto-transplant indications. And this auto-transplant activity, my guess, will continue to increase in the next few years. First of all, because of the nice and great results that have been achieved in the frontline setting. And according to Dr. Barloghi this morning, this is definitely the way we should continue to pursue. It also increasing because probably double auto will be rejuvenated in some high-risk situations. So you need to have a rich graft to do double auto. It's also increasing, and we'll hear about this in the afternoon, because we're using auto more and more in elderly patients above age 70, elderly but fit patient. We heard elegantly this morning by Professor Nagler that we are also using auto as salvage therapy. And obviously, if you want to use auto as salvage therapy, at some point you need to have a graft available to do it. So how do we mobilize stem cells? I think everybody is aware of the steady-state GCSF-based mobilization, or GCSF plus cyclophosphamide. And there is this historical belief, no evidence-based, that we use cyclophosphamide because cyclophosphamide is a good drug in multiple myeloma. So everybody's happy using G plus cyclophosphamide. However, this has a lot of disadvantages that I will try to highlight to you. Also, we are all convinced that stem cell mobilization is standard of care, but actually nothing is standardized there. We all know, if you compare the SOPs for stem cell mobilization from different hospitals, sometimes even within the same hospital from different units, you know that there are different mobilization schemas, and everybody's claiming he has the optimal and best one. Different chemotherapy regimen. Even when we speak about cyclophosphamide, actually there's no consensus whether it should be 1 gram, 2 grams, 3 grams, 4 grams, and up to 7 grams were used. Different instruments, techniques, inter-operator variability. How do you assess failures or success? Patient tolerance, we do not have data on an intention to treat, so you mobilize patient. If they don't go to the apheresis machine, actually, they will be simply ignored at some point. They are not in the statistics anymore. And impact of prior therapies. And we've seen in multiple myeloma, prior to stem cell mobilization, our regimens are definitely now a moving target, and most of the original data has been established with that. One thing for sure is the more cells you have, the more CD34 cells you have, the better is the hematologic recovery based on neutrophils, but also based on platelets recovery. And you can appreciate that something around 10 million, you would reach a sort of a plateau in terms of quick platelets recovery. So can we improve with this very heterogeneous landscape? I think definitely there is room for improvements. Obviously, we would like to avoid failures, stem cell mobilization failures. In multiple myeloma, we are more lucky compared to non-Hodgkin lymphoma, but still you have around 5 to 10% failures. But again, it depends what is your definition of failure. If your reasoning is to get the minimum 2 million, then definitely it's maybe 5%. But if you want to get the optimal number of cells, around 4 or 5 million, then you go up to 10% or more. You would like to improve the quality of the graft, and we didn't assess this in the context of myeloma because the focus has been always the drug. Most importantly, and this is something we can achieve, is to have less toxicity. And this is where avoiding chemotherapy can be useful. I will not address the selective mobilization, where we will definitely need this if we are going to start to use these genetically modified cells like CAR T cells or other TK cells and so on. Pharmacoeconomic benefit, why not? I mean, some improvement can be achieved while saving money, who knows? So we know that myeloma drugs actually can impact negatively stem cell mobilization. However, it hasn't been a big matter of concern because actually it decreased the number of stem cells, but we still have enough cells to do a single auto. We know that the IMiD, especially lenalidomide, are going to impair stem cell mobilization, especially if you have used at least 3 cycles of len-based mobilization, induction. We don't know the exact mechanism of action. We rarely hear about it, but bortezomib can also impair stem cell mobilization. This is a sub-analysis of the IFM 2005-01 trial, which was published in JCO in 2010, and in parallel, Philippe Moreau published a letter in Leukemia showing that compared to VAD, when you use VD, you have 2 million CD34 cells less compared to VAD. Still, you know, when you have 6.8, it's enough to do a single transplant. And the story may become even more complex if we start using daratumumab. I'm speculating. I don't have data. I don't have evidence. But daratumumab is targeting CD38. And we know that CD38 is expressed on progenitor cells. So we would be very eager to know the impact of stem cell mobilization after using daratumumab. So how can we improve? Today, I think the well-established, not really new drug, because it has been approved now in December 2008, so 10 years ago. Some people continue to say it's a new drug, but this is Plerixafor. Plerixifor is a first-in-class hematopoietic stem cell mobilization agent. It's not a growth factor, so it reversibly binds to the CXCR4 receptor and blocks temporarily SDF1 interaction. So this is the ligand to CXCR4. And there is now a body of evidence, clearly demonstrating the role of CXCR4 and SDF1 in stem cell mobilization. So the original experience with Plerixafor in myeloma and lymphoma could show that a single agent Plerixafor steady state mobilization can salvage 60 to 70% of patients who failed an initial stem cell mobilization, whether with GCSF alone or whether with chemotherapy. But obviously, reaching a failure is not a goal per se. So in my opinion, what one needs to avoid failures since the beginning. We always need to be successful from the first shot. This is why when you use actually mobilization with GCSF and Plerixafor, and this is a pan-European multi-center trial we run 5 or 6 years ago, you can appreciate that in multiple myeloma, after one apheresis session, because also this is important to be able to reach your target with a minimum number of apheresis, you can't do less than one, you can achieve success in 90% of the patient, and with 2 apheresis sessions, you are up to 96%. So definitely, this is a powerful and successful method, and the side effects of Plerixafor are rather very limited. You may have very, very mild nausea or some reactions at the site of injection. Historically, people were afraid of tumor cell mobilization because the stem cell mobilization can be also paralleled with tumor cell mobilization, because CXCR4 and SDF1 plays a role in tumor cells sticking to the microenvironment. Actually, it was shown, this is one publication from Heidelberg, but there are many other publications, and this is part of the approval of the drug, actually, that when you use Plerixafor, you don't mobilize more tumor cells. And we already know, I think, in the myeloma field, from at least 2 randomized trials from the early 90s, that actually relapse after auto-transplant is not linked to the tumor cell contamination. So this argument is not really relevant in my opinion. So why should we really avoid chemo-based mobilization and switch to this so-called Plerixafor plus G-CSF-based mobilization? Because actually chemotherapy, and namely for us in myeloma, cyclophosphamide, are rather toxic. This is a systematic review of many randomized trials, and I'm just quoting this publication showing that the percentage of patients requiring hospital admission range minimum 20%, 1 out of 5, up to half of them, 48%. So this is not negligible and should be considered. And we know this is due to infections. We also know that chemo-based mobilization is not predictable, so you give your chemotherapy and you start at some point monitoring your CD34 cell count. So in terms of logistic, it's not very attractive to handle this. And you don't know exactly when you have to initiate apheresis. So you have to call the patient, they have to drive, they have to come. And of course, if they get complications, you need hospitalization, you need transfusion support. So you may tell me that cyclophosphamide is an old drug and it's relatively cheap, but actually at the end of the year, it's not so cheap, because with all this, you increase the cost. And obviously, you don't necessarily calculate the cost of the transport of the patient from home to the hospital when you do your CD34 cell count. But really doing a comprehensive cost analysis, you'll end up having an increased cost. Chemotherapy, usually when you pronounce this word in the street, this is linked to toxicity. This is linked to alteration of quality of life. I've rarely seen people telling me positive things about the word chemotherapy. Of course, we do not have quality of life data assessing the role of chemomobilization, but I hope we can agree all together that if you avoid chemotherapy mobilization, it is likely to be true that the quality of life, at least during the mobilization procedure of the patient, will be better. I mean, it's very difficult to envision that patient will complain on avoiding chemotherapy. And in the myeloma field now, we're working on, giving oral drugs in induction, ambulatory drugs, and suddenly, in the middle of all this, you would like to give high-dose chemotherapy to mobilize. So this is really very weird and difficult to understand. With, for example, Plerixafor, you have also experiences that you don't need to monitor CD34 cell count. If you use it frontline, actually, your rate of success is going to be more than 95% without even monitoring the cells. So it's really a predictable kinetics of mobilization. Lower toxicity, as I explained. You improve your resources utilization. You don't need to hospitalize patient or transfusion. Your staffing is becoming easier because we have more and more shortage, of nurses and physicians and technicians. And actually, when it comes to resources, you have a bunch of studies from the US showing that you can decrease cost. And in Europe, of course, the argument was that, well, this is not relevant to Europe. So actually, we performed time motion prospective analysis in France, Germany, and Italy. This was published 6 months ago in BMT, where we could show that when you compare the pre-Plerixafor era, this is versus Plerixafor era, and these were lymphoma patients actually, you can decrease the number of apheresis sessions, so you can optimize the use of your machines, but also you can save time. You can save more than 1 hour. And looking at the number of mobilization procedures you do every year, then you can save a lot of time and use these resources to do something else. So how to optimize your cells? I think when we compare the 3 available approaches and looking at different endpoints, whether the higher probability of collecting the optimal number of stem cells, whether you consider tolerance, whether you consider predictability to apheresis, the number of apheresis session, I didn't speak about engraftment because this is not really a matter of concern, toxicity and inconvenience to the patient, but also practical, logistical, and resource benefit, and you try to tick these boxes, actually a steady state mobilization with Plerixafor and GCSF is likely answering all of these questions. So with this, I'd like to thank you for your attention. I hope I tried to save some time.